started by Dr. Xavier, sir, and it will be moderated by Dr. Apul Goyal, sir, Dr. Arun Chawla, and to our luck, our elect President Keshamurthy, sir, is also here. So, Rajendra, please record the video. We are putting all the videos in YouTube. So, over to you, sir, Professor Denis Xavier, sir.
Right, good. We can have some opening remarks from Dr. Apul and Dr. Keshamurthy on the importance of systematic reviews and meta-analysis, particularly.
Apul can give. He is the editor of our journal.
Yeah. You're on mute, Dr. Apul.
Thank you so much, and good evening, everyone. Thank you, ASU, Dr. Chandra Mohan, Dr. Arun Chawla, Dr. Denis. Dr. Denis has been taking these presentations for the last few weeks. We have covered lots of topics, case control studies, cross-sectional studies, cohort studies. We have discussed about randomized controlled trials as well. So today, of systematic reviews and meta-analysis. I think it's a very big topic, and I'm not sure whether Denis is happy with it, or we can cover it in two parts. There's lots of information to be transmitted. There are many types of reviews. Actually, systematic review is one part, but if Dr. Denis has time, he can talk a little bit about narrative reviews, the review articles we are more familiar with, and of course about systematic review, which is the topic of interest today. So without wasting further time, over to you, Dr. Denis.
Thank you very much, Dr. Apul. So, you're quite right. This is a very vast topic and difficult to cover in 1 hour. But actually, we are starting 10 minutes late, and we usually have about 75 minutes. So let's see how it goes, and also depends on interactions from people and any questions in between. So we'll try to cover both parts. However, if we have to, do it in 2 parts, we can do that as well. And I understand that tomorrow we are not having a session. Is that right?
Yes, sir. Yes, sir. You're right.
Yeah. Tomorrow, because of some other engagement for the urology folks, we're not having the session tomorrow. But the following week, we could do that. Okay, so let me share my slides and get started. Right. Okay, so it is a vast topic. Give me a few seconds to. Right. Okay, so there are 2 topics here. So one is systematic reviews and meta-analysis, and what we are planning to cover today is, firstly, what is a definition. We look at what's the difference between a narrative review and a systematic review, how to search for studies, and what are the software available, what are the AI and ML tools that are available these days. So I can't demonstrate that to you, but it's really amazing the speed at which we can do things. We are using some other software, which I will share with you. In fact, right now, a group of us are undertaking a very large systematic review in cardiovascular disease. I will tell you that. So how to extract data and summarize that. And as always, I will share some examples, both from my own work as well as from urology. Then going on to meta-analysis, we look at its definition. What are the 2 broad types of pooling methods? The random effects method and the fixed effects method. What is heterogeneity? How to assess heterogeneity? And what is publication bias? We look at. And then finally, we'll go to the last part. What are the different tools and support that is available for us? From Cochrane, what is Prospero? We need to register in Prospero. What is it? How does it work? What is Review Manager? What is Grade Pro? Each of this can be one lecture. So, but I'm just going to give you a quick feel for what these are, and then we can go and do it in more detail later on. So let us see how time goes today, and it's also since we are starting late today. in case you all want to stop at the end of systematic review, we could do that. And the next week we can do meta-analysis. Okay, so I have a few questions for you to think about. So all of you are surgeons, and all of you are aware and concerned, especially with your elderly patients, on cardiovascular risk of any surgery, right? So you send to a cardiologist for clearance. Sometimes a respirologist also looks at, lung functions and tells you what to do. And there is literature on beta blockers to protect the heart during surgery. So my first question to you is, do beta blockers affect perioperative mortality? So does or do beta blockers that we give perioperatively, does it reduce mortality? Right? And we know beta blockers help. Agreed. You'll say, oh, that is for the cardiologist, but you are the patient is yours. Cardiologist only gives a and okay. We have done a series of studies, including meta-analysis, and I will share that with you. So first question is that. Second question, what about prostatitis? Does it increase the risk of prostate cancer? A meta-analysis was done about that. We can look at the results. And I don't know whether the third question is a fun question or a real question, but does coffee intake increase the risk of prostate cancer? What do we know? And should men therefore drink more coffee or less coffee? So let's go back and actually ask you, what do you think? Anyone? Other than those people who heard my lecture last time, maybe Dr. Ginnell is not Ginnell, and anyone else who heard my lecture last time is they are not eligible to answer this question. So what do you people think? Do beta blockers, which protects the heart, as we know, rate control and also reduces the stress on the heart, does it affect perioperative mortality? Increases, decreases, no effect.
Sir, it protects the cardiac patients.
Okay,
In cardiac
so
conditions, the beta blockers protects. In case of hypertensive patient, it protects in the early morning dose. Also, it will be effective.
okay, so let's say you're going to do a transplant on a patient. It's a fairly complex surgery. So would you, Satya, give beta blockers to your patients?
Sir, I'll give, sir. I'll give.
Okay, good. You see the hesitancy?
Yes,
Like,
sir.
no, hold on. I'll tell you what it is. So this question has two flavors, okay? Two flavors. Flavor number one is, what do the textbooks say or guidelines say? Okay, that you can comment on. That's very easy. Okay. However, will you give to your patient? Wait, I have to think a little bit. And that's what research is about. Research is not in books and in websites and in journal articles. Research findings are for our patient, right? And another even more tricky question whenever I ask this of my colleagues, would you give this to your loved one? To your own family member, would you give this? Okay, so okay, any other opinions? Satya is always firstly he comes on time and he has his video on and he is always very active. So Dr. Keshavamurthy, you had to give him a special award for the most active participant in this course. Okay,
Thank you.
so you're the president-elect, and right. Okay, anyone else with a different opinion, please?
Sir, generally in routine surgeries, the anxious patient, leave apart the blood pressure, any anxious patient, we usually give, as Satya said, either night. But in case of any low BP expected, these drugs are dangerous because if bleeding happens, the drug effect will continue. We cannot monitor. So routinely young patient, generally we give if he is worried, what will happen, that, this.
Okay.
We
Beta
give
blocker.
beta blocker.
Right, Dr. Chandramohan, beta blocker to allay anxiety, okay, is a possibility, but as you know, there are better anti-anxiety medications.
Yes,
So
sir.
anyway, that's a different thing. Now, to protect the heart, cardioprotective, would you give a beta blocker is my question. Come, somebody answer. I mean, Satya as a student answered, but anyone else?
No,
Yes,
I
Dr.
wouldn't
Kesh.
give a beta blocker as a cardioprotective.
Why, Dr. Murthy?
No, I have not used it. And none of my cardiologists have used it as a cardioprotective.
Okay, okay. All right. Okay, let's go to the second question now, which is does chronic prostatitis increase the risk of prostate cancer? So, in other words, is prostatitis a risk factor for prostate cancer? Later on, people keep getting prostatitis. Would you tell them, hey, you have a chance of getting prostate cancer, so every 6 months come for a PSA or a physical exam, whatever?
No, sir, that much strong correlation between prostatitis and cancer is not there.
Okay. All right. Any difference of opinion? We're going to look at data from systematic reviews and meta-analysis shortly. So this is okay. Let's go to the coffee question. What is the relationship between coffee and prostate cancer?
Because I take coffee more, I think it is decreases.
It decreases. Okay, good. All right, so let's move on. Okay, one other question. Is a systematic review meta-analysis original research? Okay, now as you know, for NMC and for promotions in academic institutions, you need a paper, and the paper has to be an original paper, right? Letters to editor or comment here, there, and all is not okay. Case reports, case series is this way, that way. A systematic review meta-analysis, somebody says it's other people's data, it's not original research. What do you people think? In fact, I had an argument, not an argument, with an NMC inspector when I was vice dean. So this gentleman said, no, it's not original research. It is somebody else's data. It's that's not considered for promotion. What do you people? Is it original research?
No, it is not considered original research. So, but I'm not sure whether this NMC, what is the criteria, but apart from that, it is secondary research. It is not original research.
Okay. Good. Thank you, Dr. Apul Goel. Okay, I'll answer this question now because this is not there in the rest of my slides. All these three questions are coming up in the lecture shortly. I am absolutely convinced that a systematic review meta-analysis is original research. It gives the highest level of evidence. It fulfills all the requirements of a research project. And it is actually very rigorous and if not done properly, lots of things can go wrong. So I wanted you to reconsider your opinion, and I'll show you why. Okay, and I'll show you some of the work that we have done to see how. So how does it fulfill all the requirements of research? You start with the research question. There is very rigorous, reproducible, reliable methodology. All three R's: rigorous, reproducible, and reliable methodology. And then the results change clinical practice, right? And it's pretty rigorous. Okay, so let's move on. So here is the evidence pyramid. I've shown this to you earlier, and as you say, RCTs are right on top of this. What is even above that is a systematic review and meta-analysis, right? And guidelines are written based on systematic reviews and meta-analysis. Okay, guidelines committees, they of course look at all original papers and they look for high quality systematic reviews and meta-analysis. And in the next hour or so, I'm going to tell you about what is this high quality systematic review and meta-analysis. Okay, so let's move on now. Okay, so I'm of course, if we were face to face and we had a lot of people, I would have asked you to show up your hands. But even now, those of you who would like to participate in this, so just put up your electronic hand to answer these few questions. What is your experience? Any of you have led a systematic review meta-analysis project? If you could put your hands up, your electronic hand up. That means you wrote a protocol, you got it registered, and then you okay, right. Okay, I see Dr. Ginnell's hand going up. Okay, very good, Dr. Ginnell. So you've led a systematic review meta-analysis. Wonderful. how many of you participated in a systematic review meta-analysis? That means you're a co-investigator, or you at least, help with data collection, etc. Anyone? Okay, let's move on. How many of you presented a journal club, let us say in the last 3 months, on a systematic review meta-analysis? Not many. I mean, I don't see any hand coming up. And then, okay, that means the same. Okay, so in your department, whether it is a private institution or a group practice, or definitely an academic center with your, either a DNB or MCH program, did you have a journal club of a systematic review meta-analysis in the last 3 months? If you could have your hand up. Okay, so this is the usual response that I get. Of late, people are participating in systematic reviews meta-analysis, but however, not many are, not many are having a journal club in their departments. So I would strongly urge you, after you get the methodology today, to encourage journal clubs in your department. And as I told you in my earlier lectures, it's quite all right to say, we don't know this, or I don't know this part, how we did it, and let's go find out. Okay, so let's, with this little preliminary thinking that we have done, and I do hope that whatever I got you all to think about makes a positive impact as we go forward in understanding research in our own settings. Okay, so let's move on quickly with some definitions and methodology. And so a systematic review is a process of putting together or collating all empirical evidence. So the key over here is all. A very important criterion here, and this is where Dr. Apul Goel, this fits in the critical part of a definition of a research project, that there is a pre-specified eligibility criteria, right? And it's and that's how we go about doing it. Okay, why do we do a systematic review? To answer a specific research question. Yes, we are using data that's already there. There are two ways to collect data. Primary data, when you collect it from individual patients or otherwise, or data from multiple other papers, things, or data that have already been published, but with a specific research question. The methodology that we follow is explicit and systematic. It's very clear that there is no ambiguity about it. And we, like we do in all other research projects, and Dr. Apul Goel, very nicely gave a summary of all the study designs we've done. So all of them, we endeavor to minimize bias, and we have reliable findings, and we draw conclusions and make decisions for better outcomes for our patients. Okay? And that's what right, and that's why we do research. It's not just for publication. Yes, initially in our in our early career as a student and young faculty, etc., we need some publications to either complete our DNB or MCH, and then as a young faculty you want promotions, etc. But eventually all research is to improve patient outcomes. Yes, and systematic reviews help with that, and they're a critical aspect of it. And once again, let me tell you, and I'll be telling you this multiple times, and I'll show you examples as to how systematic reviews meta-analysis change clinical practice. And guidelines committees use high quality systematic reviews, either what other people have done, or they sometimes commission systematic review or meta-analysis on that particular topic before they can take a decision. Okay, what are the key characteristics of a systematic review? Number one, clear objectives. Like any other research projects, explicit, clear, right? Predefined eligibility criteria. I mentioned this earlier. Okay. Methodology must be reproducible. Somebody else doing this anywhere else in the world with the same search criteria, etc., must be able to get the same results. Okay. The search must be systematic. That's why it's called a systematic review, in contrast to a narrative review. At the end of the slide, I'll tell you what a narrative review is. In case I forget, let's stop me there and tell me, no, clarify what a narrative review is. Okay. Then we assess the validity of findings, and we assess risk of bias, and we report that as well. Remember, in all our studies, we've been saying, particularly the observational studies, where do biases come and how do we deal with the bias? Similarly, here as well, we assess biases. And finally, like all other research, it is systematically presented. Okay, the characteristics of the studies and the findings at the end of it. So here are 6 important characteristics of a systematic review. Now, in contrast, what is a narrative review? Have any of you read a narrative review? When I ask this group, many people say, no, I've not read a narrative review, and then I smile. All our life, we've been reading narrative reviews. What is a narrative review? A textbook chapter is a narrative review. That review is according to author XYZ. Right? It is, and these authors X or Y or Z or a group of authors, they are experts in the field, and they have an ability to put together important information in a nice manner. And this narrative review is according to these people. So the conclusions, before conclusions, the papers that they choose to review, which are the textbooks they look at, what other evidence they look at, is completely up to them. Right? And therefore, narrative reviews can be biased. Right? You read the management of a particular condition according to one author, another author may say either slightly differently or very differently. However, a systematic review following the same methodology done by anybody in the world will give you the same results. Okay, so a textbook chapter is a narrative review, and a systematic review is a proper research project. Okay, so now continuing on with the systematic review, we need to define the review question and the criteria for including studies. The first thing, remember, in all our other research projects, research designs, we define the objectives, we choose a study design, and then we have eligibility criteria, we have procedures in the study, etc. However, here we define the review questions and the criteria for including studies. We need to specify, just like all other studies, the population. PICO is here as well. Population, participant, or patients. We have to mention that clearly. Interventions, or whatever we are interested in. Interventions and interested in. Then what are we comparing it with? And finally, the outcomes of interest. All of this is defined clearly. Eligibility criteria. First, let's look at that. This is a key feature that distinguishes a systematic review from a narrative review. Therefore, if you have the eligibility criteria, whether you do the systematic review in India or in Venezuela or in Siberia or in Alaska, it'll all be the same. Right? Because you have the eligibility criteria and you're going to get those studies only. Okay? And there'll be an eligibility criteria for each component of the PICO. Who are the patients? What are the type of interventions? Okay, and should it be long-term medications or short-term medications, right? And what are we comparing it with? And sometimes in some studies, if there's no comparator, we knock it off, and the outcomes, and at what time we are looking at the outcomes. Okay. In some of the eligibility criteria, we emphasize specific components, and I say, I want this kind of interventions only. Okay, searching for studies. We can do a whole workshop on this for a week on how to search for studies, and it's an important step. The search should be thorough, objective, and reproducible. Why we need to search that way? We need to identify not as many. I would change this as many to all relevant studies, not as possible. All relevant studies must be identified and included in the systematic review. Now, we have Medline or PubMed as the easiest access. That alone is not sufficient. This is bad news for some of us because this is where we have easy access, right? Now, depending on the research question, it can be as few as 30% or as high as only 80% of all articles on that subject. That means you'll never get 100% of the articles. Therefore, you need to combine it with other databases. Which is the other database? The other big one is Embase. Embase is from Elsevier and it is a paid database. There are only a few institutions in India that have it. So for some of the work that I did, I collaborated with people abroad who have access to Embase as well, right? So and Embase also doesn't have 100%, but if you combine the two, you get close to 90-95%, which is good enough. So therefore, in your methodology, we need to say we use only PubMed. Okay, now of course Google Scholar is available, and now and I'm going to tell you about some AI tools. With that, possibly we'll be able to identify articles even if we are not able to maybe completely use them or get the full article. Okay, so now we have searched for the articles. Okay, one other thing I missed out telling you is we need to write a protocol. Just like every other study, we write a protocol, and there is something called a search strategy. And you can actually go to PubMed and PubMed tutorials. It will give you a search strategy. And I will tell you later on about Prospero. You need to publish this in Prospero. Prospero is the registration software or the database. You need to publish your search strategy. So if someone else wants to verify your search strategy, they can do so along with your search strategy. All right. So we have searched, we've got the articles, then we're going to extract and record the data. This searching must be done by two independent people. Extracting data must also be done by two independent reviewers. Now, and it is recorded in a structured form. Previously, we used paper forms. Now we are using all online tools to do it, and I'll show both of them to you. A good old Excel sheet is good enough, but it's a little tricky to handle them sometimes. Okay. So we record this in structured forms and then we compare. Remember, there are two people. Okay, now these two people's results must be compared. Now, 60, 80, 90% similarity will be there. That means at least 10% there will be dissimilarity. It could be just a transcribing error, right? And therefore, this needs to be resolved by a third person. So it is pretty rigorous. And I'm going to show you some of the work we did. And you can imagine some of our search itself took 1 year. Searching and extracting data is pretty rigorous. Okay, here is software to manage references. So Mendeley and Zotero are available. Zotero is free. Mendeley depends on what version you want. You may have to pay for it. I've highlighted this in a different color because this is what we use. There are several others which I have not used, but I just searched just to give you a list. Now, this is for managing the references. Now, I will show you that we're going to look at 12,000 articles, 3,000 articles, 4,000 articles. You can't do it manually. I mean, manually, not only is it very rigorous and tiring, there's a huge scope for making mistakes as well. So, highly recommended to use software to manage these references. Now, tools to manage your whole systematic review process itself. These two are what we have used, and I will show both of them to you. These three we have, I have not used them. So, but I'll show you these examples of Rayan and Covidence. Covidence is much more expensive, and then they claim to be better. We thought Rayan is more affordable, and we are managing with Rayan itself. So, here is a longer list of software to manage systematic reviews, right? EndNote, I'm sure some of you would have heard of. GradePro, OpenMeta. These are all several other tools, but I'll tell you, I'll show you Rayan and Covidence. I'll show both of them to you. Okay. So, but before that, let me show you an article which listed out machine learning and computational tools to help with systematic reviews. And this was published a couple of years ago. And look at the listing. So just for us to search, these are all the tools available. They are in 2 rows. To extract data, here are the tools available. For critical appraisal, there are tools, right? And for just screening, there are tools available. So these are the steps of doing a systematic review, right? Identifying the issue, writing a protocol, searching for studies, selecting the studies, extracting data, assessing quality, putting the data together, and then finally discussing and coming to a conclusion and using a systematic review approach. So for each of these steps, as you can see, there are so many different tools available to make our life easier. Okay, so this is Covidence. This is how it looks, but we are not using this. We are using RAYAN, and let me show you this. So this is RAYYAN, and you can collaborate with people anywhere in the world. All of us can be logging into the same system, and we can use RAYAN. So here is for our ICMR Center for Advanced Research, the systematic review. We started this on the 2nd of May, and this is my colleague who is co-leading this. At that time, we had extracted 7,600 articles. Sorry, 7,000. To manage 7,600, you need a software. Okay, we had manually managed about 3,000. That is several years ago, before we had any of this, and it was a lot of hard work, and I'll show you how that was done. Okay, so sorry, go back. So home, and then my library, and then there are, so you can have different projects that you can set up, and here are review members, multiple review members that are there. We have, I think, about 11 people working on this. I'll show you their list of names as well. So you list them out, you categorize them, and then these are all the different articles, right? And what kind of articles get. So we filtered 175 out of 7,600 using certain tools. Okay, then here is a full article that we pulled together, and more articles. You can highlight them, and you can pull them out and put them into different buckets, and organize them. So firstly, the challenge with the software is you need to learn the software first, and the whole group needs to be somewhat familiar with it. But once we get a hang of it, it's quite all right. And many of these are becoming simpler and simpler. Okay, I'll skip this part. I think, oh, sorry. Okay, so I think this one I already discussed it with y'all. This is a repetition. Sorry, I didn't put it in the right place. Okay, so now we have all of the data. Now we're going to summarize the data. Okay, now we have clear objectives, 1, 2, 3 objectives. Based on objectives, we look at all of the data, and then our mind, the human brain, is very good at recognizing patterns. Okay, we are able to recognize patterns, and of course, all of you are doctors, and you know about our neural networks that we have. So human mind is extremely intelligent to recognize patterns. Okay, because it can recognize patterns. Sometime back, remember, I told you we are not good at doing things objectively and randomly. Therefore, we are biased. Okay, and we can't do things at random. Okay, then we prepare tables. This is it looks easy. Because when you look at the finished table, it looks easy. We sometimes go through 15, 18, 24 drafts of tables. We keep on and on modifying it till we get the data, only the data that we want, and in a manner that we can understand and figure it out. Several drafts. Then we analyze the data. Okay, now we can do a narrative analysis. I just told you we do pattern recognition, and we can summarize the data. And we can say, people with this kind of prostatitis are more older, or they have these risk factors. 8 out of 12 articles said that. That kind of patterns we can figure out, right? So narrative summary is quite possible. However, the quantitative summary is called a meta-analysis. Putting the numbers together and quantifying it is called a meta-analysis. So first, we will look at a systematic review process, and then we look at the meta-analysis. Okay, so before that, I wanted to show you this project that is ongoing. I think with some of you, I shared this ICMR Center for Advanced Research. So I lead this project, and these are our regional coordinating centers from AIIMS, Bhopal, JIPMER, Pondicherry, Chennai, Assam. These are regional coordinating centers, and we have 40 other sites that are working on this project. So it's a massive program that I'm leading since last year. And one in AIM1, the first part, remember there are 3 parts to it. Okay, in the first part, the first thing is a systematic review. So I'm going to show you the process that we followed, or we are kind of winding it down now, and I'll share with you. So while I lead the whole thing, we have 2 people, my colleague from St. John's and another colleague from AIIMS Bhopal. They are co-leads, and they have a team of people. Look at this team of people from all across. So there are 11 people leading this. So frequent meetings, lots of Zoom calls, and whenever possible, we meet physically and we go through it. And it's lot of this work is done after working hours. Come back home after dinner, you sit and do some extra work because the work day is quite busy. Okay, so I'll not go through the aims and review questions and all of this, but basically what we are trying to do is finding out the landscape of cardiovascular disease in low and middle income countries, why people are not getting optimal treatment, what are the barriers they have, and what are the strategies that other people have used to overcome that, so that we can use that in our research project that is ongoing. Okay. Okay, so these are the 5 research questions. So it's called a mixed method systematic review, and the approach, this is what the approach is. It's called the JBI, convergent segregated approach that we are following. I'll skip all of that. Yeah, here is JBI, I just told you, right? So we identified 12,492, and at the end of it, we have extracted data from 246 articles. Right, and this is a table that, or this is a flow chart that we have to present to the journal as well. And I'm sure you have seen this, and this is the Prisma statement and the flow chart that you have to present. And then we prepare a data extraction form. This is how it is. Who are the authors, year of publication, title, journal, country, what kind of a design it is. This is just one part of the, and then we convert this into a software. So first we prepare it, a sheet of paper. This went on to about 6 or 7 sheets of paper, and then we put it all together. Okay, here are some examples. That was theory that I gave you. Here are some examples. First, many years ago, we did the study on what are the prevalence, risk factors, treatments, and awareness of hypertension in India. We did this project. Similarly, we wanted to look at coronary artery disease in India. So these are 2 projects that I led here, and we published them, and I'll share that with you. So here is another project where, and this is a question that I asked you, the effect of beta blockers on perioperative ischemia, and particularly mortality around surgery. So I'll share this also with you. So here is this paper that we published in the Journal of Human Hypertension more than 10 years ago or 13 years ago. And these are all colleagues from all across the country who participated in this. So we initially, this is all done manually, identified 3,372 articles, and finally we extracted data from 206 articles. This process took 2 full-time people more than 1 year. I think about 13 to 14 months we took full time, no other work they had. Two research assistants worked with us, and I had other colleagues who would meet with them every day. I would meet with them, twice or 3 times in a week, and this is how we search for the articles, extracted data, used them. All right, so there were cross-sectional studies, there were case control studies, there were cohort studies and mixed method studies that were done. And there was a quality score for each of the articles that we looked at. See, presence of eligibility criteria, selection methods, follow-up methods, quality criteria, etc. For cross-sectional studies, case control studies, cohorts, mixed method studies. All of this, we had to present this in table 1. This is a large table. I'm just showing you one piece of it. This is hypertension prevalence. Since 1971, we found articles. Till the 2000s, we found articles, and sample size, where it was done, which region of the country, what are the overall percentage, males, females, etc. This is how we summarize these articles. Awareness, treatments, and control of blood pressure as well. We looked at it. See, these are all the different authors, right? And this is the sample size, awareness, treatment. So like this, we summarize these articles. The conclusion, there were changing trends in hypertension prevalence in India. There's a significant increase, over time. There are only a few good quality studies. There are no long-term outcome studies. So we need good quality studies focusing on hypertension in India, was the conclusion of this systematic review that we did. Similarly, we did treatments and outcomes of coronary artery disease in India. So I'll run through this quickly. So here again, close to 4,000 articles, and we included 288 articles. And this is the quality scores for these articles. And this is in hospital and post-discharge medication use, thrombolytics to beta blockers to ACE inhibitors, so on and so forth. And this is outcomes that were reported in these different studies. That is how we put that together. Okay, let's go to this third example of perioperative beta blockers. This is both a systematic review and a meta-analysis. So I'll present only the systematic review first. So, all right, here. So lots of people undergo non-cardiac surgery, right? And guidelines committees advocate using perioperative beta blockers. And maybe Satya would have looked at that and said, maybe that's why we should do this. However, some authors said, how good is the evidence for this, right? And therefore, this is a close friend of mine, Dr. P.J. Devereaux, who is a cardiologist and a global leader in perioperative ischemia. In fact, Dr. Ginnell, this study was also done at Amrita Kochi in early in 2000. Another time I will tell you about this. So I had friends in Amrita Kochi even before I became friends with Dr. Ginnell there. Okay, so let's move on. Okay, so this is the research question, and the outcomes are major cardiovascular events, including mortality. Eligibility criteria. So, okay, so this is inclusion and exclusion criteria. This is trial identification. Remember, I told you about Embase, Medline Embase, hand searching, consulting authors, and many other search strategies that they used at that time. So assessment of study eligibility, 2 individuals independently evaluated eligibility. There is a statistic called the kappa statistic. It's called the agreement statistic. And sometimes we use it in other research projects as well. Data collection and quality assessment was a priori. Again, 2 individuals independently abstracted data and consensus to resolve disagreement. Right. So they started with close to 5,000 articles, and many of them were like 4,900 were excluded because they were non-randomized designs, and that is not reliable data. Observational studies will tell you, beta blockers are good or bad, and they were very, very stringent, and I will show you how stringent the meta-analysis was later on. So finally, out of 4,900, only 22 articles fulfilled good criteria to be included in the systematic review. Okay, so this is the quality measure. Remember, concealment of allocation, whether the trials were stopped early, whether patients were blinded, healthcare providers blinded. So these are the quality criteria that the authors decided to use, and some of them were excluded because they did not fulfill the minimum quality criteria. Right, so here is table 1. This is the designs of the different RCTs used in a systematic review. So first author, year of publication, sample size, type of surgery. This is elective surgery, carotid endarterectomy. This is ENT surgery. This is gynecological surgery. This is cholecystectomy. This is neurosurgery, and so on and so forth. It continues. I'm just showing you one piece of the article. What was the intervention? Metoprolol, esmolol, metoprolol again, esmolol here again at the time. Okay, length of follow-up, end of surgery, discharge, etc. So this page actually, and sometimes if you see, they go to 2 pages on both sides. They print them, and sometimes they print it the other way around. You have to turn the journal. Of course, these days we flip the PDF. We rotate the PDF and we see it. But those days we had to turn the photocopy or whatever to read these elaborate tables. Okay, so this is systematic review. Based on this, we can make certain conclusions. However, what is a meta-analysis? Meta-analysis is a statistical technique for combining the results of 2 or more studies, at least 2 studies. Okay, let me give you a question here. It's always good to stimulate our thought. Give me a few seconds, please. Let us say the relative risk reduction in one trial was 15%. And in another trial, it was 20%. If we pool these 2 together, what do you think would be the pooled relative risk? And that's what a meta-analysis is, correct? So one is 15% and the other one is 20%. If we pool them together, what do you think would be the answer? The pooled relative risk. Anyone?
First, we had to assess the weightage for the study by assessing.
Wait, Dr. Ginnell. All my questions you are not eligible to answer. I think you're listening to this for the 3rd time, correct? But I greatly appreciate it. So wait, we will get other people who have not thought of it to think a little bit. Anyone? Do we need a calculator?
So, is it just an average of both, like 15 plus 25 divided by 2? It will be 17.5. Just a random thinking.
Wait, Satya, when
Sir, it
somebody
will
asks
be,
you a question, you don't ask another question. You
Right.
either give an answer or say, I don't know. So your answer is 17.5?
Yes, sir.
Okay, good. Anyone else?
sir, it is between 15 and 25, depending upon the weightage of the study. It
Who's speaking? I can't see you people. Depending on the, now what is the weightage of the study? Okay, the correct answer is we don't know. The correct answer is we don't know. But an answer that both Dr. Ginnell, where Dr. Ginnell, you disappeared now because I told him he's not eligible. Dr. Ginnell, you are eligible to be in the okay. So the answer is we don't know. The correct answer now, Dr. Ginnell, please explain to all of us because you know the answer. It depends on the weightage of the study, is what you began to say. But please feel free and explain to us in your words what you get by weightage of the study. Yeah, please go ahead. You're on mute, Dr. Ginnell. Please unmute. Please unmute.
If one study has got only 100 patients, the other study has 900 patients, then actually the 900 patient study has to give more weightage than the 100 patients. So according to that, the percentage has to be, importance has to be given to the different study.
Right, right, absolutely right, absolutely right. And one other person who I couldn't see the person's name uh, also said something similar. So the answer to my question is I don't know, and the answer or the pooled relative risk depends on the weighted average of each of those studies. So we just had two. So I gave you a simple situation. Okay, so let's move on. So it's a statistical technique for combining the results of two or more studies that ask the same question. And now we can pool results from any studies. However, observational studies as well as intervention studies, we can pool those data. High quality meta-analysis pools data from systematic review. So therefore, we say it in the same breath. It's a systematic review and meta-analysis. So you don't take any article that you find and put them together. So good quality. So when you say I've done this meta-analysis, the question that they'll ask you is, did you do a systematic review before that? Okay, or are these articles chosen based on a systematic review? Okay, advantages, we increase power. There is precision, improvement in precision, and we can answer questions not posed by certain individual studies. And sometimes we settle controversies arising from conflicting claims. What are the types of data that we can pool, right? We can pool dichotomous data. That means, of course, at the first, the next session will be introduction to statistics. So I'll tell you the types of data. So we can dichotomous data, yes or no, continuous data such as PSA levels or hemoglobin or weight or whatever. These are all continuous. Anything that has a decimal point, okay, they are continuous data. Ordinal data, ranked data, counts and rates, time to event, survival. All of these data can be pooled. Okay. All right. Here comes a tricky situation. What are the models for pooling? There are two broad models for pooling. One is called a fixed effects model, and the other one is called a random effects model. The textbook definitions for these two are a little bit complicated, and the statistics behind it is a little complicated. So, and you know, my role over here is to simplify certain complicated things that are there. Now, I'm going to introduce another topic in the next few minutes or so, something called heterogeneity. Now, firstly, I told you that we are going to use studies only that fulfill an eligibility criteria. That means they have to be somewhat homogeneous, but at the same time, these studies are going to be heterogeneous. Types of heterogeneity I'm going to tell you in the next few seconds. However, simply put, when studies are more similar, that means heterogeneity is less, we use the fixed effects model. However, when studies are more dissimilar, they're all over the place, but they fulfill the eligibility criteria. Okay. And usually we get quite heterogeneous studies. When we get that, we use the random effects model. Once again, when studies are similar, When they're more similar, we use the fixed effects model. And when they are more dissimilar, we use the random effects model. Random effects model is more conservative, and journal editors are more likely to accept if you use a random effects model. If you use a fixed effects model, you have to convince the peer reviewers and the journal editors. This is the reason why I used a fixed effects model. So once again, random effects model is more conservative. Now, let me give you the textbook definition. I'll allow you to read it. So in a random effects model, we assume that all studies, if they were infinitely large, we would have identical results, and any observed difference is due to random error. Now look at random effects model. Firstly, that the studies are from a random sample, okay, and each study estimates a different underlying true effect, okay, and anyway, so I'm sure you don't appreciate this definition. So was my definition simpler and clearer? When to use what? Okay, so we'll stick with that and not go through. And there are other definitions as well. Okay, let's move on. First, let's look at heterogeneity. So one thing, a common pronunciation error that many people do is they call this heterogeneity. There is no C in this. Look at the spelling, there's no C. But very commonly people call it heterogeneity. Well, there is heterogeneity in the study. I asked them, where is the C in this? Oh, no, sir. Oh, no, sorry. Okay. So there is, so one is we need to pronounce it also correctly. Okay. So it is pronounced heterogeneity. There is not heterogeneity. Okay. What is heterogeneity? Heterogeneity is the variation of effects between studies. Although they fulfill an eligibility criteria, studies are different. All right. There are two types of heterogeneity. One is called clinical heterogeneity, and the other one is methodological heterogeneity. Now, let us say you are saying, I'm doing a systematic review of prostate cancer. What type of prostate cancer? What grades of prostate cancer? Not all studies will be the same, right? They're going to be different. As long as they fulfill your definition of prostate cancer, you include them. That is clinical heterogeneity. What is methodological heterogeneity? Okay, now let's actually look at it. So clinical heterogeneity is the type of population, the intervention used, and the outcomes. Methodological heterogeneity, on the other hand, is the design and the quality of the study. Okay, maybe you're going to do only randomized controlled trials. Some of them will have 40 patients, some will have 400, some will have 4,000, right? Some of them will be before-after studies. Right? They may not be concurrently randomized studies. The quality of the studies may be quite different. The duration of follow-up may be very different. All right. So that is methodological heterogeneity. Now, how do we assess heterogeneity? When you read these papers, you will know there are ways. One is you can just eyeball you make the table and then you can see it. Okay, follow up to the types of interventions, etc. So you can just eyeball the data. Then we can test for heterogeneity to explore if the observed variability is just due to chance alone. Right? There are many tests for heterogeneity. I will show you, or I will tell you only the commonest one. One is called the Cochrane's Q. The other one is the I-square. Okay, and don't worry too much about for the moment as to how exactly they are calculated. They are statistical tests to assess heterogeneity. And I will tell you a little bit more about I-squared because that's quite commonly used. Okay, so at the end of it, you will get a percentage. How do you interpret I-square? Now, if it is 0 to 40%, not important. 30 to 60% moderate. 50 to 90% substantial, 75 to 100% is considerable. Are these numbers okay? Are you happy with it, or is there some issue there?
There is in between some gap.
There is some gap. Okay, suppose we calculate it and say it is 55% heterogeneity is there. 55% falls in between these two. Correct? 55 is here and is here as well. So is it moderate or substantial? Okay, suppose we say 80% heterogeneity. Is it here or here? This is not an error. This is deliberately put. It is just a guideline. So it's up to you now to interpret it depending on various other factors as well. So that is something that I wanted to tell you. Right. In the interest of time, maybe we will conclude with publication bias. Okay, what is publication bias? And these days, publication bias is a little lesser because we have to register all our studies. Okay, but still there can be publication bias. Publication bias occurs when the outcome of the research study biases the decision to publish. Okay, now if you all have done trials and you got what we call, many people call it a positive result and a negative result. I think last time I told you, right, there's nothing called a positive or negative result. Okay, it's either a well-conducted study or not a well-conducted study. If it's not well-conducted study, throw it, let's not discuss it. If it's a well-conducted study, did you achieve your primary objective, or did you show that your intervention worked or not? All right. Anyway, so let's assume our intervention did not work. Then what do? You're not so excited, right? And then you don't publish that, right? But these days, when you do a trial, I'm sure all of you know, and I told you last time as well, you have to register your study, and then the registry will be after you. Every year they will send you a email. Please update the registry. And one of the questions is, have you published it? If you're not published it, they will ask you why. It's unethical not to publish trials, right? It's a patients have agreed, and we have to do. So assessing publication bias in a systematic review and meta-analysis is also important. Okay. So what happens is, because this publication bias disturbs the balance of findings in favor of positive results. So more positive results are published and less negative results are published. So negative results are also important, provided they're well-conducted studies. All right. Negative means that the intervention does not work. We need to show that. Okay. So how do we assess publication bias? One is we can do it visually, and another one is statistically we can visualize them. All right. So this is a funnel plot. Okay. Now, the middle line is a risk ratio. The middle vertical line is the risk ratio. And on this side favors control, and this side favors treatment, and this is sample size. And as sample size increases, initially when sample sizes are small, 30 and 40, it will be pushed to either extreme. And as sample size increases, it will go towards the middle. Now, you are looking at it visually. Do you think there is symmetry in this plot? Do you think there are equal numbers, more or less? Not exactly, don't count the dots now. just look at it. There are equal numbers of, using the old terminology, results that favor the control and favors the new treatment. What about this? Don't worry about the axis now. Look at it. What about this? Compared to this, this is symmetrical visually. This is not symmetrical clearly. Correct? All right. So this is a funnel plot, and a funnel plot goes either in the main paper or definitely as a supplement in your paper. Statistically also, we can assess it. One is called Egger's test using regression techniques. The other one is a Beck's test using odds ratios. So we need to compute this and also show to the readers and the reviewers before that that publication bias was there or not there. Okay, so now I'm going to conclude here. But before I conclude, let me, 1 second, I'll stop sharing. Give me a few seconds. I'll conclude today's session and I'll tell you what else is there. Dr. Apul Goel was right when he said, this is quite a vast topic. Okay, so let me now show or just mention to you what else we have. So I'm going to later on in the next session tell you how to read a forest plot. Okay, how do you look for heterogeneity? How do you look for the treatment effect? Where do you look for the 95% confidence interval? So how do you read a forest plot? And then the same example of a beta blocker that I showed you earlier, I will show the results and I'll show you a trial that we did. Okay, so that was the POISE trial that we did. Okay, then afterwards, we will look at some examples from urology. Remember, I told you about chronic prostatitis and prostate cancer. There's a meta-analysis that was done. I will show that to you. The same thing, we look at coffee consumption and prostate cancer, a meta-analysis there. Then I will give you 12 steps in doing a systematic review meta-analysis. I will introduce you to Cochrane. I will introduce you to Prospero, to Revman, the latest version. Assessing risk of bias, we look at Grade Pro. Then we will look at network meta-analysis. Then we will look at an example from urology, which used a network meta-analysis to do that. So, and then of course, finally, in the end, we will summarize. So these are all the topics for next time. So I will stop now. I don't want to keep you too long. It's already been a long day for everybody. And I drove 6 hours today, non-stop. And I just got here about 45 minutes earlier prior to starting this, and I had a quick cup of tea. I can go on if, but it'll be too late for it. It'll go on till 9:15, 9:20. It'll be late for you. So I'll stop here, and there is time for some comments or questions, please.
Apul?
So excellent presentation as always. Okay, so there are certain things that you raised these points. So journal clubs we do have, but typically we tell the residents not to present review articles. They are more like seminars. So so the emphasis, it's a rule actually that we present only original articles. That helps them in writing the thesis as well, because when they know what is introduction, what is material methods, how to write results. So that is what it is. Regarding just a few clarifications.
Dr. Apul, could I
Yes.
just come in here? And that's why we do seminars, and I greatly appreciate all of you seniors and very accomplished people listening so carefully at the end of it. So at this moment, Dr. Apul, hopefully you have at least a small change in mind that this is original research, and there is methodology here, every part that we spoke about. So in 2008, I took over as the head of department, and then we reviewed our academic program, and then I, as I think I told some of you, 2005 to 2007, I was away in Canada. So 2 years I lost touch with the academic program in our department as well. So within a year of my returning, I took over as head of department, and we reviewed this. Then I asked our staff and our postgraduate students, what are the different types of research designs that we need to look at? Otherwise, we were doing only 2 types of articles. We were doing only randomized control trials or animal studies. Then I asked them, what about observational studies? Are they important? We usually don't do it. Okay. What about systematic reviews, meta-analysis? We never did that before. Okay, but of course, I went and I did a whole course on systematic reviews and meta-analysis, and I was totally convinced that this is hardcore research. And as I showed you in that evidence pyramid, it sits right on top. There is methodology. So my humble request to all of you, and all of you all are seniors, you'll make policies for the urology community and other surgical communities as well when you speak to your other surgical colleagues. So to consider definitely a systematic review and a meta-analysis as a research design, and to use it in journal articles. And next time, Dr. Apul, once we do the meta-analysis and I explain to you a forest plot looking at I squared, and these days we have a first year postgraduate student where we have debates. Why do they use a random effects model and not a fixed effects model? So those are the debates that we have. Right, and how do you interpret the I-square, and how do you do this, and was the eligibility criteria okay or not? Is the conclusion okay or not? So of course, step by step we could do that. Sorry, I interrupted you, but I hope.
Hey, I think.
Yeah.
So thank you for answering. Actually, we are a bit afraid of too much statistics, and it becomes difficult, if there are long tables to project and to discuss those tables. So they need a lot of time. So that may be one reason. Okay, so another thing is that supposing there is already a meta-analysis which is existing. So, and if you want to answer the same query, because the literature keeps evolving and keeps changing and new papers keep coming up. So after how many years is there a criteria, So when you can write a new meta-analysis or a new review article. So if there's a already existing review article, say, for example, it was published last year in 2024, whether if there's a submission, the same sort of research question comes after only 1 year. So is it right to, write such article or publish?
Okay. Let me answer this question, and also I'll give you a personal example. Okay. Even if there is one additional article that has been published after the meta-analysis is done, this can be included, and another meta-analysis can be done. Okay, and I will show you this example next time, where one well-conducted trial changed guidelines, a trial that we were involved in. Okay, and that's very important. So even one additional trial is published, they can be included, and a fresh meta-analysis can be done. Okay, now during COVID, the BMJ set up what was called a living meta-analysis. And in fact, I presented during COVID for, I can't recall which society was this. Anyway, during COVID, we were making so many presentations sitting at home. We got so I was really excited to see this living meta-analysis. What does the living meta-analysis mean? That means the meta-analysis is ongoing, right? And anything new comes, it's fed in, and then and then a new meta-analysis appears. So evidence for treatments, there were so many treatments, starting from hydroxychloroquine to steroid to antivirals to all kinds of things were there, and then they were all being fed in, and including the living meta-analysis. We also had network meta-analysis to make indirect comparisons. Next time I will share that with you. It's very fascinating. So I will urge all of you in the next 1 month to attempt a journal club. If there are 8 out of 10 answers we don't know, that's fine. We at least discuss 2. At least we know that 8 items we don't know, and that is knowledge. Knowing what we don't know is important knowledge. It's in fact the starting of accumulating knowledge. Awareness of what we don't know, not just to avoid it. And so, Dr. Keshav, you just remarked, we are not good at statistics and these complex tables, we don't know how to deal with it. No, the fact that you said it, and you being a senior person, and also in nothing, and it's really very gracious of you to say that, in front of other people. That is the start of humility, and awareness of the lack of knowledge is the first step. Right? And I'm sure you've heard this. The most dangerous person on this planet is somebody who does not know something important and does not know that he or she does not know. That is dangerous, and it's some important information. Okay, anyway, we can go on and on, and yeah, so the next time when you see this, you'll be really excited. And I'm not sure we have this in our course this time, on how to conduct journal clubs. I actually do a session on how to conduct journal clubs and how to present the data. That's very important. Most times people cut and paste and have crowded slides, and we don't know, we can't make it. And a big table is put, we don't know where to look for. Right? So I will share with you some insights that I have used, and I teach quite often on how to present journal clubs and how to have a practice or a habit of journal clubs regularly in our departments. I'll share that as well. Yes, Dr. Apul. Yeah, for the
Thank you
thoughts.
so much for the input. Thank you. Thank you. So, Dr. Arun wants to say something.
Yeah, the Apple, excellent. I'm in the flight, which is just starting. So many thanks to Dr. Danish for showing the insights into how to conduct a systematic review. But I think is every time we learn new things, we have much more to gain from him. I think with this we'll sign off with the next classes, which are scheduled for next week. Thank you very much.
Thank you.
Yeah, thank you, Dr. Arun. And I think Dr. Keshav wanted to say something. Please, Dr.
Yeah,
Keshav.
I'm keen that you do a journal club, this thing, how to conduct a journal club.
Yes, and actually at the end of
Yeah, we have in this, Dr. Danish, we'll keep a provision for at least 1 or 2 sessions on Journal Club after the third section of this research management, and that after that we can have.
yeah, definitely we'll do that. Yes, Dr. Keshav, please continue. Any other thoughts?
No, thank you, Dr. Dennis. It was a very enlightening session for us, at least. So we look forward to the next sessions also.
Right.
Provided Chandra Mohan times it at 7:30. Because if he times it at 6:30, I will not reach home by that time.
Yeah, where is Dr. Chandramohan? This is the presidential decree now. Okay, so the incoming president says you got to do it at 7th. I'm okay, personally okay, but depends on everybody else. One other thing that I noticed now majority of the participants, other than Satyanarayan and few other people who I don't know, they have OnePlus and 2Plus on iPhone. I don't know their names. I see most of you are faculty and senior people and teachers, which is wonderful, and I really appreciate your forthrightness to say, okay, let me come and learn, and therefore you can teach as well. I only hope more students join this. Right, it's meant for them, and I told Dr. Chandramohan, you make it free and you make it totally flexible, people will not respect it. Anything that comes free, isn't it? Right? Sometimes we feel if it is free, people will take it. So anyway, I don't mind. I keep
No,
telling people, if one person ready to
that's the
listen.
generation we are dealing with. Dennis, if you have a session on Eurofinance, it will be full. You will not find a space.
I
That's
know,
the situation now.
right. I know. Anyway, good. So we will let Dr. Keshavamurthy sign this off with your final remarks.
Thank you for all of them for joining this, and I thank the ASU for conducting this webinar. Thank you, Dr. Dennis.
Thank you.
Okay, so see you next week on the 29th. 29th is our next session.
Thank you.
Okay, bye-bye. Good night.